Welcome to our Integrated Medicine Grand Rounds, and thank you all for coming. So our tradition with these Grand Rounds is that each month, we're very blessed in Boston to have so many different centers for integrative medicine throughout the community. And so today's presentation is from the Dana-Farber Zakim Center for Integrative Therapies. And we're very, it's wonderful to have a wonderful team presenting that's going to be led by Dr. Weidong Liu, who's the lead oncology acupuncturist at the Zakim Center. And also Emily Biever, who is a nutritionist at the Zakim Center, Dr. Sharon, who is a senior psychologist, also there, Dr. Douglas Brandoff, who's a hospice and palliative care medicine specialist, and also a medical oncologist and hematologist, and Nancy Campbell, who's exercise physiologist. So quite a team here, and can't wait to hear their wonderful presentation. And also, I want to just please remind those of you, if any of you have not signed in, going in, please do so going out so that we know who you are and we can also inform you about future events. So, Dr. Liu.
Good morning. Welcome to this grand round. I'm very excited to have our wonderful team here with the nutritionists, Emily Biever, Dr. Sharon Bauer, and the Nancy Campbell, our clinical exercise the specialist, physiologist, and Dr. Brandoff, and he is the specialist in the palliative care and the co-director of the palliative care clinic at Dana-Farber Cancer Institute. For most, I will appreciate our patient, Mr. David Feldman, and his wife right here with us, and really appreciate it for his willingness to participate in this grand round and share with us his experience to go through this cancer journey. So the Zakim Center was for integrative therapies at Dana-Farber Cancer Institute was funded about 15 years ago. The center was set up to dedicate to integrate the practice of complementary therapy into traditional cancer treatment. The cancer also provides complementary therapies and education to patient, families, and the staff. And meanwhile, the cancer also doing actively on the research front and try to advance the knowledge of effectiveness and outcome of integrative therapies. We also offer individual services such as acupuncture, massage, Reiki, and integrative medicine consult. By the way, we have our Zakim Center team right here. We have Dr. Ziping Lee and Dr. the Bambi Masai and the Teresa, and also former director of the medical director of the Zakim Center, Dr. David Rosenthal, also with us today. Besides the individual service, we also have a group program, including movement, creative arts, and meditation, including Tai Chi, yoga. You can see that in mind-body programs. So in terms of prostate cancer, this is a big problem for men. According to statistics, the prostate cancer, actually every man have very high chance to develop prostate cancer in their lifetime. So you can see here it's 1 out of 7 men and will have prostate cancer. In past few years, the treatment about prostate cancer has made a greater progress. The 5 years relative cancer survival rate has increased from 68% to 100%. But prostate cancer still remains as the largest top number 1 cancer among men. This is 2015 numbers, and 220,000 patients will develop prostate cancer, and it counts about 26% of all the men and with the cancer. Let's talk about the patient, the case. This patient is 63 years old, male, with a high risk of prostate cancer. At that time when he's seeking acupuncture treatment, and he was diagnosed with a T1C, NX, and M0, and he had a PSA level and 5.52. His Gleason score was 8, and with perineural invasion positive in nature. Otherwise, he has a very good condition. Meanwhile, that's when he started this supportive care, he was undergoing this therapy called androgen deprivation therapy and also radiation at the same time. By looking at his history, he already started to have elevated PSA as early as 2008. Then he was given the finasteride and for the symptoms of the urination symptoms, and his PSA actually went down. Then his PSA gradually rise up again, and in the 2012, and then gradually in the January 2013, that was PSA level was 6.43. At that time, he started the medical attention and undergoing the biopsy in May 2013. That showed about the 6 out of 6 core positive, and on the right side. And again, his Gleason scored 8, and with the perineural invasion, which is one of the feature of the disease. Then he also underwent this MRI exam and reviewed the multifocal masses in the bilateral base. The bone scan, however, showed that there is no sign of the metastatic disease. So this is the chart of his PSA history started from 2000. You can see the blue dots was the normal range, and the red shows the elevation. The highest was in January 2013, and at that time, and he started to seeking medical attention. His past medical history, he had low testosterone, he had the BPH and the hypertension, obesity, and diabetes, and various medical conditions. No significant family history of the cancer. And he is a practicing divorce lawyer, and currently still very active. And he's had a smoking history for about 17 years, and quit it in 1982. He also takes some medication, including baby aspirin and lisinopril, multivitamins. And the physical exam at that time revealed his prostate is smooth, bilateral. There's no nodules, no hemorrhoids. The review of the history systems, he had some nocturia, but not severe, no dysuria, no hematuria, and occasionally have some urgency. The sexual function was good erections, and no history of the vasectomy, and no urinary incontinence. So, so what is high-risk prostate cancer? High-risk prostate cancer only accounts for about 15% of total prostate cancer patients, and he's one of them. According to American Urological Association, the definition for high-risk prostate cancer is that they need to have preoperative PSA greater than 20, which he didn't, and or have a preoperative with the Gleason score 8, between 8 and 10. He did have 8 on the Gleason score. That's put him into high-risk prostate cancer category, and all have a clinical stage of the greater than T2C. The tumor size, which he did not. This category of the prostate cancer had 5 years of relapse-free survival probability, ranging from 49 to 80%. This is a Gleason score, how they diagnose and divide them in different categories. Essentially, low Gleason score means a slow-growing tumor, and a high Gleason score means a fast-growing tumor. The patient at that time was offered to this standard of care, the androgen deprivation therapy called ADT plus external beam radiation, which consists of the injection called the leuprolide every 3 months, and also the oral tablets by calutamide every day, and in addition, he receiving the radiation treatment with the intensity modified radiation therapy. Unfortunately, ADT and radiation therapy come with a significant amount of side effects upon the patient receiving this therapy. As you can see here, that the patient has a very high prevalence, have a reduced penile and the testicular size, anemia, the gynecomastia, and breast pain, hot flashes, sexual dysfunction, and metabolic and cardiovascular events, and cognitive dysfunction, fatigue, and even skeletal bone-related events, such as fracture. The patient, actually, when he first started the treatment, he did not start supportive care, and you can see from this chart that he actually started the supportive care during his most intensive treatment, when he received 3 treatments at the same time, radiation, leuprolide injection, and bicalutamide pills. So, however, after he started this supportive care, he continued, you can see with the blue bar, after even he completed the anti-cancer treatment. At the time he received acupuncture treatment the first time, he had a significant amount of symptoms such as hot flashes, fatigue, insomnia, anxiety, constipation, and depression. The aggregated symptom score at that time was 44 out of a total 60 at this time. The patient, at the time, he had most significant is the persistent hot flashes, and he had hot flashes 3-4 times episodes each night, and accompanied with profound night sweats, of course, affecting his sleep. That's why he had these hot flashes, depression, insomnia, anxiety, fatigue, these symptoms. He never had acupuncture before he came to the Dana-Farber. Actually, his acupuncture was recommended by his oncologist, and they told him, say, come to try the acupuncture. And once he started, and he did not stop. And he continued acupuncture for 18 months. And by the April 2015, he had a total 79 sessions with acupuncture on average once a week, once acupuncture every 7 days. And at the same time, and he also studied other supportive care, including nutrition and the psychotherapy, physical exercise, meditation, Tai Chi. He gradually embraced all this supportive care into his care. So now I turn the podium to our patient, Mr. Feldman, and would you please just come to here to share our audience about your experience. Let's welcome.
Thank you very much. I am honored and pleased to be here, and I'm very happy to share my experiences. I feel that there's not enough of a discussion of this problem in the medical community, and especially with patients. I myself, like Dr. Liu had said, I had about 2008, my PSA started to go up. I was told I had BPH. I went through, took various medications to deal with the BPH at that time. And I know the cutoff on the PSA is 4. And I was in the 4s, and then I flirted with 5, 5.5. But I really didn't think I had cancer because I didn't have any symptoms. And when I had exams, when the urologists examined me, they said, well, everything seems normal. Finally, a doctor at the Brigham, Dr. Doyle, Christopher Doyle, who was a great man, since retired, convinced me that I should have a biopsy anyway. And I quite honestly, frankly, I was shocked. I thought that I was, from what I was able to determine, I had about a 1 in 4 chance. That's what he said. That's what I was able to research on various authoritative sites. And I was shocked when I found out I had cancer. My cancer wasn't particularly advanced, thank God. I was in a relatively early stage, but I was also shocked when I found out that I had Gleason 8. And Gleason 8 is the lowest rung on the high-risk scale. Although I'm lucky I did not have any of the other factors that would indicate high risk. And I really knew very little about prostate cancer. I don't think I really wanted to know anything. I don't think most men want to know. It's, it's something that you try and keep out of your mind, hoping that you don't get it. And I very quickly went from the Brigham over to Dana, And I would never forget my first day at Dana. I met with the radiation oncologist, who did a fantastic job, and I met with the medical oncologist and the surgeon. And the surgeon, to his credit, top surgeon, talked me out of surgery. I assumed naively that I was going to have surgery. And he talked me out of it. I thank him for it. And I had been made aware over at the Brigham here by the urologist that there were various treatments, including radiation and ADT. These were just words to me. These were just things I just didn't really listen. I listened, but I didn't really understand it. And after my first visit at Dana, the medical oncologist says, "Well, why don't we start you today?" And and my wife was there, my wife Sandra, and he says, "Look, we're going to give you a shot. We're going to give you an injection of a drug that's going to stop the cancer from growing. It's going to shrink the tumors." So of course, and they gave you a sheet at the time. Well, he had a bunch of charts and stuff, and everything was very vague, couched in maybes and this and that, but never really discussed. To be quite honest with you. Never really discussed the rather devastating side effects that, almost universally accompany ADT, including the sexual side effects. They tell you, I know the doctors say that, 80 or 90%, that 10 or 20% of men are not affected by that. I've yet to meet any of them. I wish I knew who these 10 or 20% men were. But anyway, suffice it to say, it was in the late afternoon, and he sent me down to from the 11th down to the 9th floor at Dana, and where there was a nurse who did the injection in the infusion section, and she seemed incredulous. She says, "Well, you're going to have Lupron. Do you know about Lupron?" And he says, doctor told me this is going to, shrink my tumors and stop the cancer from growing, blah, blah, blah. And she hands me this sheet, this single sheet of paper that lists all these side effects, and I read it, and this and that, and I had the shot, but I was completely blindsided by the complete, total, and devastating side effects from this drug, as Dr. Liu, quite ably explained to the side effects. I had most of them. I had cognitive difficulty, which is great concern to me because I'm a practicing attorney. I'm a trial attorney, and I had at one point I even fractured my foot. Of course, I was told that that it was not related to my treatment, and I did have a bone density that showed that I still had normal bone density, but I had most of those side effects. I had severe depression, anxiety, insomnia, great difficulty sleeping, not to mention, very frequent hot flashes. And these things. So the doctors, when you go for your follow-ups, they give you, am I running out of time? They give you a sheet and you circle the different things, and then they tell you the only thing they could really offer me was Effexor. And at some point, I realized I was really on my own. And I decided that I needed to take matters into my own hands. I needed to be responsible for my own medical care. And that's when I reached out to all of the people who are here today, Nutrition, Emily, Dr. Biever, who's been counseling me, and Nancy Campbell. And I've used my 4 minutes? Yes. Okay.
So now this is a chart that shows the patient that went through his treatment along with the supportive care. And now we'll turn the podium to Emily, and she will talk about the nutrition counsel to our patient. Welcome, Emily.
So yes, he's still doing acupuncture. He's still with nutrition too. Thank you very much. So as we know, with chronic nutrition or really lack thereof, we see association with disease prevention, disease occurrence, and prostate cancer is really no different. Specifically, when we look at BMI, so excess adiposity tissue, there are correlations with occurrence of prostate cancer, but then also in terms of risk for reoccurrence. With greater BMI, greater chance of recurrence. So you can see those percentages are pretty high. So when we work with nutrition with our patients that have prostate cancer, obviously we want to, change their body composition, reduce their adiposity, bring their BMI down. And then, of course, we want to look at what they're eating. A prudent diet, what is actually something we don't call it a prudent diet at Dana-Farber, but in this particular research study, they call it a prudent diet. But we definitely concur with this heavily plant-based diet, so lots of colors, lots of phytonutrient-rich plant-based foods, fish, whole grains, versus what we refer to as more of a Western diet, so a lot of processed foods, high red meat intake, processed meats, and a lot of heavily and refined processed foods. So this particular study that was actually just published in 2015 noted that there is an association with more of a Western type diet and prostate cancer specific and all-cause mortality. And this isn't terribly surprising. We have this understanding that diet is really closely related with how people go through their treatment and then afterwards in terms of survivorship. Specifically with David, again, he started working with nutrition in 2013. So realizing, and that was, I think, one of the gifts, is recognizing that nutrition and all of these different services here or over at Dana-Farber were really important. And so he hopped on board with these very early on. And as you can see, 2013, his weight was 129 kilograms. In April, he got it down to 117. And if you heard all of those side effects that he was experiencing, this is unbelievable. Truly. He's kind of like a rare gem of my prostate cancer patients because he is so determined to make these lifestyle changes, and that's the result. This is very hard to do with ADT therapy, and he's done it and he continues to do it. So his specific nutrition journey, which I want to dive into a little bit, because I think this is really what makes that kind of progress and success possible. He's embraced a new lifestyle. So he has incorporated a much higher veg, fruit, fish, low-fat, dairy, eggs type of diet versus a Western diet. Does once in a while, does he go out and enjoy? Is he still a human being? Absolutely. And we talk about that. That's huge for people to still feel like they can go out and enjoy picnics this time of the year, this time of the year, cookouts, barbecues, and have hot dogs, hamburgers, or whatever. But then what David would continue to remind me of, he'd say, and then the next day, I got right back on it. I got right back to it. And that's why we see this continued weight loss for him. And then, because it is a lifestyle change, what are these healthy foods that he can incorporate that he loves? Because if we start incorporating healthy foods and they're not enjoyable, this lasts a few days and then it's done. It becomes a quick, fast diet that's not long-lasting. So David's really been able to find foods that are healthful, that work in part of a prudent diet, but they're lifelong. Portion control, and really I included this balanced eating throughout the day. When we first started working together, there were days where there was no breakfast. There was, maybe some light lunch, and then dinner. Like any of us, we tend to overconsume. So he started really making sure he was fueling himself evenly throughout the course of the day, which ended up making a really big difference in overall less calories consumed. Reprioritizing, this is a message I give to everybody that I work with. Where is nutrition, physical activity, where is it in your list of priorities? And so in order to have these foods available, we need to be thinking about them, and we need to plan and have our nutrition, have our physical activity higher up on the list of priorities in terms of our self-care, not at the bottom, or this wouldn't be possible. And then finally, I think, as David acknowledged earlier, there's a lot of anxiety, there's a lot of stress, all these side effects, and so it was really easy to get discouraged when the scale went down a pound from 1 month to the next, or it stayed steady, because then he started doing some more strength-based exercise, so his muscle mass was going up, so there were times when the weight just stayed steady, and that can be so discouraging. We were really going for healthy weight loss, but I'd have to remind him, what are your labs? What do your labs look like? What does your A1C, remember type 2 diabetes, A1C usually is higher with uncontrolled diabetes. His A1C was dropping like crazy. He was weaning off of medications that he had used for other more chronic health issues. So we'd have to come back and point to those. Look at all of these. This is what's going on inside of you, which is huge for survivorship. So celebrating and acknowledging everything that he's doing well in terms of nutrition and physical activity. So I'm enjoying continuing to work with David. He's doing an exceptional job, and he's a great kind of role model for people that are going through prostate cancer.
Thank you, Emily. So now let's turn podium to Dr. Sharon Barber, and she's here to talk about psychotherapy and sexual health.
Oh, great. So it's a pleasure to be here, and I have to say, I don't think I ever want to do a talk again without David, because there's nothing I can say that's going to be more articulate than what you just said in terms of your own experience. So the unfortunate reality for men on ADT is that the symptoms and the totality of experience that David just described is actually completely typical. This is not something that's extreme. This is not something that we don't typically see. But this is really a kind of hallmark of what so many men have to sort of sit with and live with day to day. So we're talking about not just significant rates of sexual dysfunction, and I agree, the elusive 10% out there I have yet to meet as well, but that this is really an existential crisis, okay? So beside the kind of very concrete symptoms that we're talking about, I want any one of you to imagine what it would be like to essentially be neutered in your mid-60s, to essentially lose your sense of identity as a man or as a woman, depending on, just imagine what that would be like. You really don't feel like yourself. You lose your sense of vitality. You lose your sense of motivation. Your body is completely not the body that you're used to. You're in your body, and you're looking at your body in the shower, and it's like you don't know what is normal anymore. Okay? So it is really a profound shift in identity day to day, as well as a kind of a symptom list. And that, especially if you're in a relationship where sexual functioning was intact to begin with, where you're used to having kind of intimacy and day-to-day relations, and that all of a sudden is just gone. So we see that often men who are in good relationships with healthy sexual function are actually more distressed, because when you imagine what you're losing, it's significant. And all of this is not surprisingly related to anxiety and depression, right? So these are the kinds of, this is the starting point. And I think that what is really important to take away from this case is that the fix is not one-dimensional. There is no pill, there is no one piece of the pie that can fix everything. But this is a fantastic case to really symbolize what we mean by integration of care. Okay, it really is at the intersection of mind and body and soul that things have to come together for people to have a shift. So in terms of what David and I have worked on together, and that also includes work in a sort of a relational context as well as an individual context. We sort of have taken a very much of an integrative approach, thinking about what it means in terms of sort of at the basic, the mechanical level, right, in terms of penile rehab. I mean, everybody has profound erectile dysfunction. The good news is that there's actually a lot we can do about that. Most men don't know about many of those things. So, for example, I don't know if you noticed, there was low-dose Cialis, okay, on the list of medications. That's something that we think about in terms of rehab. What does that mean to sort of get fresh oxygenated tissue to that penile, fresh oxygenated blood flow to that penile tissue when you don't get that naturally anymore? That's really important for reducing damage to that tissue over time. That's something everybody should know about. That's something that we don't talk about as regularly as we should. So there's a sort of a penile rehab piece. We also had to think a lot about what it means in terms of sexuality and intimacy, to think about just what it is to sort of become aroused, what it is to sort of think about intimacy, not just from a mechanical point of view, but what does that mean when you are having profound hormone deprivation and you don't feel like yourself? What does that mean to be able to feel sexy, to feel aroused, to sort of engage in intimacy at a sort of a level in which it's really not just about what you do, but how you think and how you feel, right? So that's a mind-body connection there. And similarly, in the context of psychotherapy, just really sort of engaging the kind of questions about what does it mean to still feel like yourself? What does it mean to be a man? What does it mean to be a lover? What does it mean to be a partner in the context of all of this? And also sort of to think about how you engage the partner. Because for all men who go through this experience, partners actually have similarly complicated experiences. We actually know from research that often partners have more distress than patients. So really important to also sort of take a relational perspective as well. I'm sorry, it's a busy slide. It's hard to sort of say everything in 5 minutes, but just to say quickly, guiding principle here, I think, is that we're not just the goal, at least in sort of sexual health medicine and sex therapy, is not just to say how do we make things the way that they were, how do we go back to the way things were, because that might not be possible. But it's really about sort of saying what does it mean to be where we are right now, to expand our experience of what sexuality and intimacy is, and to redefine that in a way that works. And similarly, sort of, David again exemplifies what it means to be an active patient who is autonomous, right? Who is taking control of one's own experience and really sort of being the captain of one's own ship. So doing homework, being active outside of sessions, so important. And also just to say that in terms of the connection between sexual health and mental health. I mean, certainly my role here has been more sort of around sexual health in particular, but there are, these things are so connected. So I think for so many guys who go through this experience, who we know are feeling depressed and anxious, I think much of that experience is often informed by the existential changes, including how you don't feel like yourself and you don't feel like a man. And so I think if we can sort of find ways to sort of do counseling in an integrative way where we sort of bring all of that together, it's not just changes in sexual health, but mental health and emotional health and relationships that sort of grow in a positive way together. Thank you.
Thank you, Dr. Barber. So now let's see Nancy Campbell, the clinical exercise physiologist. Nancy?
Good morning, everybody. So I will concur with Sharon that I want all my presentations with David. And if only all of our patients were as motivated as David, it would make our day-to-day experiences a little bit different. He certainly exemplifies hard work and dedication and really putting together a fantastic team that he has done really well. And I think that's what's great about working as part of the Zakim Center is that we're able to really integrate. As Sharon said, it's not one of our roles. It's all of us together really helped you couldn't remove one of us. We all sort of have helped along the process here. So I was lucky enough to meet with David a little over a year ago. So he was already along on his journey when I met him. And, partly through his own dedication, and I, will credit Emily as well as sort of, incorporating in her initial nutrition talks with him that, exercise was also a very key component. So she really kind of helped guide him, and he was already walking when I met him 4 to 6 times a week, 60 to 80 minutes. I mean, that's fantastic. It's very rare that I meet people, again, through radiation on, side effects of the ADT. And David was, persevering and pushing through these symptoms and getting these walks in. Fitbit, 13,000 steps a day. I mean, I'm lucky, if people even know what a Fitbit is. If they have it, they're lucky if they're maybe getting 5,000. I mean, typical Americans get about 5,000 steps. So again, David, overachiever here, doing great at 13,000. The component that was missing and that had really sort of driven Emily to recommend coming to see me was the strength training component that had never really been sort of a formal part of his routine. So he was looking to add that in. So some of these goals we've mentioned already, losing the weight. And as Emily showed, he has done a fantastic job with that, which is, again, an incredibly rare occurrence. Given the side effects of ADT, to not, for most men, it's gaining weight. So even if people maintain, we're happy. But as Emily said, we're ecstatic to see that David has done so well. lowering the A1C levels, and adding the strength training to his routine. So he has really, done a fantastic job achieving all of these goals. So I just included one of sort of the early studies here. This is back in 2009 when the tide sort of started to turn and there was a lot more focus on, hey, I think exercise can be really helpful to mitigate a lot of these side effects from ADT. And since 2009, there have been, probably 50 to 100 more of these studies, some smaller studies, 20 patients, 30 patients, but really trying to get larger, more randomized control trials that have had fantastic results from not a significant amount of exercise. So, this study, resistance exercise 3 times a week, aerobic exercise 3 times a week, but really, one of the few ways that, can deal with a lot of these side effects, in particular fatigue, but also this one, a lot of quality of life, strength losses. We talk a lot about the ADT therapy and the increase in fat mass and the decrease in muscle mass, so this is great. Triglycerides, body fat. So exercise was really a tremendous one of the things that they didn't really focus on here, but has sort of been a larger focus more recently, are the bone issues. Bone density loss winds up being a big issue for these guys, and again, not necessarily a lot of options in that department. So strength training has been really helpful in that, and there's been a lot more focus on sort of refining the exercises and figuring out what type of exercise will help, in particular with the bone part. So David was fortunate enough to get a membership to the YMCA and participate in what's called the Live Strong program. Fantastic program for cancer survivors, twice a week for 12 weeks, completely free. Trainers all know what it's like to work with these patients, so they know how to modify things. Okay, we need to take these issues into account. It's a group environment. You finally get to meet some other cancer survivors. The other 80 to 90% of men who are in this same pool, you get to mingle with them and meet them, and it's really, we're so fortunate to have that program in a lot of our Ys. And I think a long-term goal for the YMCA, and we've done some studies here to really try to get that in every YMCA. So every prostate cancer survivor has a place to go to exercise with other cancer survivors, and then in a safe environment with trainers that know what they're doing and understand, the nuances here. So I thank you guys. This is really a fantastic case, and thank you, David.
Thank you, Nancy. So after all his treatment and look at his PSA level and dropped significantly after ADT and radiation and continue to remain low until latest, May 2015. So that was a significant indication that his cancer is to be well under control at this time, and possibly we don't know if the cancer is cured, but it's a very, very good progress at this time. Then his symptom score also significantly reduced over this time while he receiving all this supportive care. And you can see the trajectory and the reduced. And I remember at the time his symptom score was a 44 out of 60. And at the last 79th acupuncture treatment, he had about only 11 out of 60 symptom scores. And the good news also, that show his testosterone level after he completed ADT treatment actually starting rising, and he's coming back. His weight also significant. You can see also the trend in going downward. That's credit to the exercise and nutrition and maybe possible acupuncture. So what is acupuncture? The evidence, we are quickly go through these. These are studies, mostly they are single-arm clinical trials regarding the acupuncture before and after the ADT treatment to measure mostly when the hot flashes. And you can see here, and this is another study, and this is another study on the ear acupuncture. This study compared these two different models of the acupuncture, electric acupuncture versus the manual acupuncture, that showed about the 78% and the 73% reduction of the hot flashes scores before and after. And this is another systematic review that the patient, breast cancer and prostate cancer patient had a persistent reduction of the hot flashes even after they stopped acupuncture treatment. And from this data, this at least about 3 months to 6 months after they completed acupuncture, they still will see the benefit, about a 45% reduction. However, because of these studies are single-armed, so this is the review that showed this evidence could be considered as a tentative, and we need a randomized, more rigorous controlled trial to confirm these findings. Well, this gives an example. There's a breast cancer treatment, randomized 3 arms, and shows a significant reduction in the hot flashes, but this is not for the prostate cancer. These are acupuncture mechanism. We skip that because of that. We'll talk about a little more. Now, beyond the hot flashes for acupuncture, the NCCN, which is the authoritative group that issues the clinical practice of a guideline in oncology that recommend acupuncture for adult cancer pain and anti-emesis and fatigue and palliative care as well as survivorship. So now I have our discussion, Dr. Brandoff, to come over to give us some summary on today's presentation. Let's welcome Dr. Brandoff.
Thank you, Weidong, for this opportunity. I want to start by thanking the most important person in the room, who without a doubt is David. I think it's really mind-boggling to me how patients can often be robbed of the opportunity to share or lack the invitation to share their experience. That's something that needs to change. And what I have found is that in other venues where patients have had the opportunity to share, it promotes a sense of connectedness, it increases awareness, and can have a very positive impact on how we approach patients. It's also part of the very supportive care that we're alluding to in this presentation, and I've learned not to underestimate the power of that therapeutically for patients themselves. Learning that one has cancer is life-altering. It is disruptive. It can promote many physical, emotional, and spiritual and existential side effects that are nothing short of profound. This is not an anomaly. This is not a surprise. We have data and we have common sense that would suggest this would be the case. Unfortunately, what David lists today is not unusual. Fortunately, on the converse, we have a village, we have a group of colleagues, inclusive of our oncology colleagues, who can anticipate and treat for these issues, account for them in a very individualized, holistic way from day one. Within palliative care, we like to say that it's available at any stage of illness, including at the time of diagnosis for any duration through what could be curative intent therapy. That holds true for the integrative model that my colleagues have so compellingly spoken about today. Not every discipline that's represented here may be the right fit for a given patient. We should not assume that. But to offer it, to make reference to it, to promote it, not to potentially denigrate it unwittingly as a soft part of care or any less important than the ADT and RT and surgery XYZ that our oncology colleagues talk about. This is, in fact, core to the mission of trying to heal, because, in fact, we are not treating diseases. We are promoting healing in our patients who are thrust into a patient role they didn't ask to be in. There's an unwanted bedfellow of cancer that wasn't requested to join in their lives. This is not my slide, but what I will say on it is it reminds me of the Venn diagram that Dr. Betty Farrell at the City of Hope, a prominent palliative care nurse scientist, has taught me and many others, which is we are integrated people in terms of the physical, psychological, social, and spiritual domains. It's a little bit like a graphic equalizer on a stereo. Ultimately, how we're impacting one area, we need to think about the other areas and account for them as well. The amount of suffering that our patients can have, and I say this not to victimize anyone, but to, in fact, validate the experience, again, can be profound. But so, too, can be the interventions that we can provide. I learned in elementary school you are what you eat, and I think everything that Emily spoke about today confirms that. We can make a decided difference from day one. Actually, we can all in this room promote making a difference before day one to stack the odds to the best degree possible in our favor. I don't know that that would have changed David's Gleason 8, but we can see how after the Gleason 8 was determined, look at the difference that component of his care has made. Sexuality, intimacy can be a beautiful thing. It is core to the human experience. And as Sharon alluded to, it's all too often considered taboo, playground material to joke around about. It's core to who we are as people. And it needs to not be the forbidden subject for discussion and exploration at the Dana-Farber and like institutions. It actually needs to be inquired and normalized and pursued and cared for. What a difference that can make as someone is enduring the harsh nature of some of these treatments. So too with exercise. No pain, no gain. Athletics. You know, we see all the folks on TV who are breaking records, and I certainly celebrate, for example, the Women's World Cup. But for those of us who are mere mortals, how can we each move ourselves along on the exercise spectrum and do a little bit more and gain some momentum from that and build into the mind, body, and spirit model that's been espoused here today? It's something that I think we have the opportunity to promote to benefit patients. As far as palliative care, I love to interface with Weidong and other colleagues here, sometimes with medications and a lot of the time not with medications, or frankly in combination. It need not be this morbid undertaking of seeing any of us, but it can be, as my colleagues have said, life-promoting, life-enhancing. How do we take this cancer experience and this treatment experience and turn it on its head and make it into something where we're promoting well-being while knocking out the cancer to the fullest extent we can? I do appreciate this slide, which I want to briefly make reference to. We have evidence now in the New England Journal of Medicine in 2010. A thoracic oncologist and palliative care-minded colleague at Mass General, Dr. Jennifer Temmel, published this study which for the first time examined in a more rigorous context how patients might fare with early palliative care versus whenever an oncologist or patient might ask for it, and it was specific to the metastatic non-small cell lung cancer population. In brief, it showed that there are improvements in multiple indices, including pain scores, some of the other quality of life symptoms, fatigue, nausea, bowel dysfunction. It also improved mood scores in terms of anxiety and depression. But as the curve here also suggests, there is a 3-month survival benefit that was found as well. We are trying to duplicate and replicate and build upon this study in other illnesses, but it has certainly given a platform for expanding upon and extrapolating from what this important study showed. So in summary, what I'd say is, yes, David is extraordinary, and I'm not saying that just because he's here, but everything I've heard today convinces me of that. So too can be extraordinary the results of an integrated approach, and for us to think of that proactively and preemptively rather than after unnecessary suffering is endured by our patients. I hope, David, that this good fortune continues for you, and I hope that we can all build upon this integrated model and bring it to more patients who would similarly benefit. So thank you.
Thank you, Dr. Brandoff. So now we are, these are what we learned here today, and at the last, I would like to thank our Zakim Oncology Acupuncture team, and we have some team members over there, and they all joined with me together, cared for David during his cancer journey, and I would like to thank for our colleagues at this here. So now we are moving into our question and answer session. We'd like to ask our co-presenters to come forward and sit in the chairs, and we're taking some questions from the audience. Come here. David? Yes.
Wonderful presentation. Thank you for everyone's thoughts and input one question I had is that there may be the appearance of there was a high utilization of care, repeated appointments and such. Can anyone comment on what may have been the alternate experience had you not, or how was the cost of care impacted by this type of integrative approach?
I think at that time, for the David and the Zakim Center, the acupuncture service provided he has to pay himself out of pocket, and but he ultimately felt that was worth it, and so he continued. David, you have some.
Yeah, I can make a couple of comments on that. Look, when I saw what the charges were for the radiation, it was thousands. I had 42 radiations over a 3-month period, and the bill was just extraordinary. I believe that I was going to see Dr. Biever every 4 to 6 weeks. I'd say 4 to 6 weeks on nutrition. Nancy Campbell, I met with her only a couple of times. There was, at Dana itself, there wasn't a men's exercise program, but there's a women's exercise program at a facility that's just around the corner. I think that it was worth it. There were extra co-pays, of course. There was the cost of the acupuncture, which was subsidized as well. But I think this is a small price to pay. Some of the medications nowadays with the copays can be very expensive. It's not uncommon at $50, $65 copays for medications. So I don't think it was anything unreasonable.
Thank you. Yes.
Are you saying that most of these treatments are not covered by insurance? Is that a general statement? I mean, I have advanced metastatic prostate cancer, and I'd like to engage myself in acupuncture to start, but I'm not able to afford the full amount. That's a personal question, and you don't have to elaborate on it, but I'm just concerned about it. I'd like to know whether the system is supporting these therapies at this point or not with insurance.
I could comment on that very briefly. My insurance has been very good. I have Tufts. They've paid for quite a bit of it. They allow you a certain number of visits to nutrition. Dr. Bober's services has been covered by the mental health portion of my coverage. The only out-of-pocket of great significance has been the acupuncture, and Dana is 25% cheaper than the going rate on the outside, the cost at Dana. So that's...
And one other follow-up question. If I can remember what it is. The presentations that I've heard this morning seem to be leaning toward early-stage prostate cancer. I'm not early stage. I had a very unusual case of 16 years without cancer after radiation treatment, and all of a sudden it shows up extensively in my skeleton. And I'm wondering how many of these comments today relate to me rather than someone in early stage. There's still, all of these things that we're talking about doing, I should be doing.
I don't think any one of us can speak to your particular experience because we don't know you, but I think I don't think so. I don't think any one of us can speak to your personal experience, but I would say in general, I think all of what we spoke about are all of these issues around nutrition, exercise, sexual health, mental health, and the kinds of treatments that we can sort of bring to bear, I think are all relevant for men with both advanced disease as well as men with early stage cancer.
Thank you.
Oh, by the way, regarding the acupuncture coverage, and at the Zakim Center, we do offer financial assistance for the patient with a need. We do provide free service for 12 sessions out of a year as needed.
I just wanted to offer a brief reflection on the state of acupuncture and insurance coverage. And Weidong and I have collaborated on a number of patients for whom I've attempted to write persuasive letters to insurance companies. And it's been an interesting homogeneous experience of rejection, which has been frustrating for patients. I think of one in particular for whom, when we think about distribution of cost, when we think about suffering, this is a lady who's had extensive hot flashes and sweats. She's had evaluation up the wazoo. She's been hospitalized for it. She has seen a number of specialists with all of the attendant costs. And the one thing that has worked for her unequivocally has been acupuncture, to a point of having it 2 to 3 times per week at height of frequency. If ever there were a compelling case and person's experience that I could cite and try to procure a change with an insurance company, it was this patient's case. And the runaround that I received, well, it's not in our coverage of benefits. I know it's not. That's why I'm writing this letter of appeal. That's why I'm quoting the NIH consensus on acupuncture. That's why I'm quoting my colleagues' erudite knowledge of acupuncture, how it can help this patient, how it has helped this patient. It's stunning how much they would not budge. So it's a work in progress, and I think hopefully as the evidence base grows, we can advocate for our patients and have this important service increasingly covered, or at least subsidized.
Thank you. Yes, a question here?
I just want to say that Good morning. I'm a volunteer at the Virginia Thurston Healing Garden in Harvard, Mass. It's way out in the boonies. But we offer all kinds of supportive care, including acupuncture, massage therapy, art therapy, music therapy, a whole host of things without any financial barrier to the patient. We're a small center, but I encourage anyone going through the cancer journey to investigate us at healinggarden.net.
Thank you very much. Next one? Yes, yeah.
I'm just curious if Dana-Farber is doing any or thinking at all about adding any Chinese herbal medicine to the practice. I know when you're my herbal teacher, Lou, so I'm just curious.
This question is we can discuss it later. And at this time, we do not offer any herbs, and but we from time to time we do have patients bring the herbs come in, especially with Dr. Rosenthal. He's the expert and offer the medical counsel, and we do examine the herbs and give some advice. We do not offer it, but we do give advice at some point. Next one. Oh,
I just wanted to make a comment, especially the gentleman that had a question about advanced cancer, that the Zakim Center actually sees the entire spectrum of patients. So we are blessed to be able to serve people that are just newly diagnosed, advanced disease, to survivorship and also end of life. And it seems that a lot of the research and our clinical experience show that we're able to at least empower patients to continue with quality of life regardless of where you are. Mm-hmm.
Yeah. By the way, I think the OSHA Center organized these grand rounds, and our patient, Mr. Feldman, actually is not just only the patient of the Zakim Center, but also the patient of OSHA Center. He has the wonderful teacher teaching him meditation class. He was very active. We should mention this, Dr. Yes, Dr. Paulson is right here. And David, you want to say something? Yeah.
Yes, at some point during my therapy with Dr. Biever, we talked about strategies to help me with my anxiety, to help me become a little bit more focused, to help me with depression. And she mentioned to me, I never really heard of the Osher Center, directed me to the website. It was very conveniently located for me because it's in Chestnut Hill, right on Route 9. It's about halfway between where I live and Dana-Farber. And I took I believe it was a 12-week class with Dr. Paulson, who's here today, and I found it extremely helpful, and I've managed to integrate it into my life and use it quite frequently. And it also sparked an interest in yoga. I've just recently, which is something I had difficulty with, I've recently been doing yoga as a result of the meditation. It's kind of like one thing led to the next. One last, I know I talk a lot, but one last thing I want to mention about the acupuncture. It's most frequently referenced with regard to the hot flashes. I found it helpful in many other areas, particularly the anxiety, the depression, the insomnia, some of these areas, the energy thing. It became something that became part of my life. It's kind of like a biofeedback system that helped me progress in my struggles with these side effects. And at this point, you know, I'm in post-treatment recovery and doing quite well. And to reference that gentleman's indication, I don't think there's any time when treatment really ends when you're a cancer survivor. It's something that's a lifelong process. Unfortunately, cancer doctors really don't know when and why and with who it's going to come back and who it's not going to come back. So I think it's important to try and do these things as part of your entire lifestyle. Thank you.
Thank you very much. We have a time we have to end here, but we'll have coffee time and just social time. Yeah, Dr. Paulson? Yes, yeah.
No, I just wanted to say this is an echo of Dr. Brandoff's comment about the value of having a patient's voice in a conference like this, which is that those of us who work in integrative contexts, often, if we're humble, we have to admit we don't know how our various treatments actually integrate with each other. We're all deeply trained in various traditions, and we work in concert with patients. But I think one of the values of this kind of event is that it sort of fills in the middle of the Venn diagram. We get to hear the patient's voice. And it's not so much that they explain how we integrate, but it just sort of completes the sense that in each patient's experience, there is integration occurring, and we get to see how we relate to each other. So.
Wow. Totally agree. Thank you so much for this beautiful presentation. It really exemplifies what we were hoping these grand rounds would do. And thank you so much for